So I'm going to briefly go over the management of hyperglycemic crisis, which includes both DKA and hyperosmolar states. So, of course, DKA is the most common hyperglycemic emergency that you will see, both for type 1 and type 2, although for type 2 it is much rarer. And it has significant morbidity and use of healthcare resources. As many of you are aware, you have a lot of patients who keep getting admitted with the same problem repeatedly. And the thing is that for type 1 diabetics, you're actually spending about 1 in 4 healthcare dollars for management of DKA. In fact, each episode of DKA costs at least $11,000, which is more than a couple of years worth of insulin treatment, even if using the most advanced insulin regimens. So it's a very expensive thing which can be prevented, and that's why it's important to not only treat these patients but also try and prevent it. And it is costing, these are 2005 figures, which are about $1 billion a year in terms of healthcare costs. So you can see here how these, the number of episodes have been increasing, partly related to, some of the things related to our actually treating this better. The mortality rate, even though it is still there, is significantly lower now than what it used to be. So in developing countries, the mortality is as high as 5 to 10% with DKA, but in the United States it's less than 1%. So mortality still can occur, but it's very rare. So in 2005, of course, there were 120,000 discharges, and but among type 1 diabetics who are less than 45 years of age, this is what you see, about 55 per 1,000 diabetes admissions. And that's because most of the DKAs occur in younger type 1 diabetics. By the time they're 50, they probably have learned how to deal with it, or they have other medical problems, so that this is not their major reason for getting admitted. So it's important for us to educate the patients straight off the bat when they're diagnosed with type 1 diabetes on how to prevent this problem, and which is actually not too difficult to do. So I'll first start off with these two conditions, which kind of overlap in some ways in terms of their presentation and also in some of the pathophysiologic mechanisms on why they occur. So diabetic ketoacidosis has the picture of severe hyperglycemia with blood sugars generally more than 250 milligrams per deciliter. They're acidotic, they have wide anion gap, and have a low bicarb with moderate to large ketonemia or ketonuria. On the other hand, patients with hyperosmolar hyperglycemic states have very high blood sugars, usually greater than 600. pH is usually greater than 7.3, higher bicarb, mild ketonuria or ketonemia, and serum osmolality is greater than T20. So these are the ones that we are generally using. But you should remember, particularly in for hyperosmolar hyperglycemic states, that because of the presence of comorbidities, which are usually the precipitating factors for development of hyperosmolar state, you might find coexisting other types of metabolic acidosis, so that you might find them to have a lower pH or a higher, or a lower bicarb, mainly because they could have lactic acidosis, or they may have renal failure. So there are other reasons why it may be, but ketones are very minimal. Ketones are generated anytime you don't eat for some time or when you're starving. So that's why finding ketones in the blood or urine in itself does not automatically give you a diagnosis of diabetic ketoacidosis. So you have to keep these in mind. Most of the time the diagnosis is easy. Sometimes it may be a bit of an overlap and sometimes difficult to do. So here what we have is an absolute insulin deficiency, and that's why you get these three problems. And it usually develops over hours or 1 to 2 days. And of course, most of your type 1 diabetics will tell you that they were fine, that nothing happened, and only this morning I started throwing up, and they're here with severe ketoacidosis. And it can happen, it can occur over hours, or generally takes 1 or 2 days to develop the full picture of diabetic ketoacidosis, because the main problems related to diabetic ketoacidosis is more related to fluid depletion and electrolyte imbalance than the acidosis itself. So that particular presentation, will take about a day or 2 to develop. There is a large variance on how patients with DKA present, and some of it is related to why they develop this problem, and most commonly in type 1 diabetes, the reason why this happens is because they don't take their insulin as recommended, or they skip doses of insulin or don't take it at all, and that's one of the reasons why they are developing this problem. So there may be no other underlying problems that you see. But increasingly we see patients with type 2 diabetes who develop DKA, and these are patients who are very severely ill. So at that point there is a significant reduction in insulin production, near absolute insulin production will be reduced, and also they are insulin resistant, but they also break down too much fatty acids, which is why they generate more ketones. On the other hand, here with hyperosmolar states, you have relative insulin deficiency, blood sugar goes up very high, and there is no significant ketone production, mainly because they have some amount of insulin. So when you look at the insulin dose response curve for different effects of insulin, as you know, insulin reduces blood sugar. That's the most easily quantifiable effect of insulin. But it also decreases potassium, pushes potassium into the cells. It decreases free fatty acid breakdown, so it is anti-lipolytic. It has effects on muscle protein synthesis and a wide variety of effects that it has. And what you find is that to prevent the generation of ketones, you actually need very small amounts of insulin. So if you have enough insulin to prevent ketone production, you may still not have enough to prevent severe hyperglycemia. So that's the reason why you will not develop ketones, even though your blood sugar is going very high. And when you have absolutely no insulin, that is when you develop ketones. So this is just a general outline. As you can see here, that the basic mechanisms are here, which is lipolysis, increased free fatty acid delivery to the liver, which actually is what leads to increased ketogenesis, which then causes a decrease in alkali reserve and ketoacidosis. And you will find that if we don't generally do this, but if you measure triglycerides in these patients and fatty acid, they're very high in patients with DKA. And of course, the severe insulin deficiency is what causes the hyperglycemia. On the other hand, what you have in hyperosmolar state is actually the insulin resistance with increased gluconeogenesis, hyperglycemia, osmotic diuresis, dehydration with impaired renal function, which in fact worsens this hyperglycemia. So most patients who present to you with hyperosmolar state actually have severe degrees of dehydration, and they also have varying amounts of change in mental status, which is why they don't drink enough fluids to compensate for the glycosuria and polyuria that they have. So that's what leads to this worsening hyperglycemia eventually with hyperosmolarity. So this is the main difference. That means that this process of developing hyperglycemia is common to both, but the ketogenesis is the fact that you need to be severely insulin deficient to have a problem of ketogenesis. Otherwise, you can always prevent ketogenesis. So this is the overlap that you have. They are overlapping syndromes, and you will find some patients with, or a significant number of patients with type 1 diabetes who are in ketoacidosis are actually also hyperosmolar. So in many studies, and particularly in pediatric age group, the morbidity and mortality in type 1 in diabetic ketoacidosis is actually more correlated with osmolarity rather than acidosis. So, which actually indicates the extent of dehydration, probably also the duration of the problem and worsening renal function. So those are the patients who have more severe illness if their osmolality is very high, as opposed to those who only have acidosis that is very high. Of course, hyperosmolar state, they're usually older individuals. Mortality in hyperosmolar states is high, partly because of the fact that these are older individuals, and these are individuals who come into the hospital because of a second problem that they have. It's usually in the form of a cardiovascular event, could be an MI, could be a stroke, or they have sepsis. So there is a second illness which actually makes their risk of dying quite high. So it may not be just the hyperosmolar state. Whereas often in patients with type 1 diabetes, diabetic ketoacidosis is their only problem. They come there because they didn't have enough insulin. But if they have any underlying illness, if they are septic, or if they have if they have MI or other illnesses, their mortality also is higher. But fortunately, for most patients with type 1 diabetes, DKA is simply because of not having taken enough insulin for a variety of reasons. So how do they present? Thirst, polyuria, abdominal pain, nausea, vomiting, profound weakness is their typical presentation. And of course, the physical exam, there's really nothing much that you will see. They have rapid respiration, fruity breath. I don't know how many of you really dare to smell their breath. Something that we don't usually do. Relative hypothermia, they're tachycardic, and basically they are severely dehydrated. That's the typical picture that we see. And just by these findings, you're really not going to distinguish between hyperosmolar state and diabetic ketoacidosis. It's the question of what type of diabetes do they already known to be having. Lab findings. This is where you will really make the diagnosis. Blood and urine ketones are positive. Severe hyperglycemia, low bicarbonate, and a high anion gap, low arterial pH, and low PCO2. So that's the thing that we always check for. So it is a high anion gap metabolic acidosis. So obviously, whenever you find this, you will have to think of other possibilities for this problem. If you have ketoacidosis, there are two things that we mainly look at, which is diabetic ketoacidosis or alcoholic ketoacidosis. With starvation, you'll get some ketones, but you're not acidotic. You will get mild amounts of ketones when you are starving, but you'll not be acidotic. Of course, you'd also be lactic acidosis, although sometimes there may be an overlap, uremia, and other poison. So you always keep that in your differential diagnosis when you see a type 1 diabetic presenting with a wide anion gap acidosis. Of course, your top 5 diagnosis for someone with type 1 coming with the wide anion gap acidosis is diabetic ketoacidosis. Now, you should also remember that the acid that is accumulating, the ketones that are accumulating, is beta hydroxybutyrate. So doing a urine ketones is useful. It's quick, but it mainly is measuring acetoacetic acid. So that's why beta hydroxybutyrate and serum ketones are better measures of ketoacidosis than urine ketones. In the past, we used to not only check the serum and urine ketones initially, but also follow them. We no longer do that. We only need it for a diagnostic purpose. Once you have done that initially, you don't have to repeat that again. You just do, because our indicators of resolution of ketoacidosis is actually the anion gap. So rather than keto circulating or urinary ketones. So that's why there is no reason to do a follow-up measurement after the initial measurement. That actually saves you time and effort to not do these things. Okay, so as I said, it's fairly simple to make these diagnoses. So this one is, this is an 89-year-old lady, seen in a nursing home, diabetes for 15 years, treated with sulfonylurea for 1 year. Then she went on to be on insulin, and the blood sugars are widely varying between 50 and 300. Takes NPH and regular insulin, means 70-30 insulin, and during a recent episode, her insulin was withheld, concerned that she would consume fewer calories. And in the evening, she had a blood sugar of 513, She had prior history of stroke, coronary artery disease, and colon cancer. She's lean, and dipstick urinalysis shows glucose and ketones. So, does she have ketoacidosis? No. Her blood sugar is 513, and she has urine ketones and urine glucose. Is she a type 1 or a type 2 diabetic? Which one? Type 2? Okay. So that was the question that was asked here, Is she type 1, type 2, secondary diabetes, or latent autoimmune diabetes of adulthood? The reason I brought this up is because most people are used to looking at type 1 diabetes as an acute event. It starts at a younger age, and that's how it presents. Well, that's how it presents in the majority of patients. However, there are type 1 diabetes can occur at any age. So you can get an 85-year-old who can develop type 1 diabetes, and you can have a 2-year-old who can develop type 1 diabetes. So age itself, and while the majority of type 1 diabetes is in the first and second decade of life, it can occur at any age. The second thing is that type 1 diabetes is an autoimmune disease. You develop reactivity against your islets. This process is actually quite slow. In most patients, there is a second event which we don't know what exactly those are, which rapidly precipitates the decline in beta cell function. But in some individuals, it does not. It takes a long time for them. So they will present. So this patient actually has what we call latent autoimmune diabetes of adulthood. So what she has is type 1 diabetes. It's an autoimmune diabetes, but it develops slowly. And you can see that she's a lean individual. She was on sulfonylurea for 1 year. So it presented initially. She had some reserve of beta cell function. And then she needed to be on insulin. And while on insulin, you can see that her blood sugar fluctuates a lot. She's only on 22 units twice a day, but it ranges from 50 to 300 in any given day. And she has she's a thin individual, a BMI of 21. So she's actually a type 1 diabetic, but she developed this problem slowly. So that's what you call latent autoimmune diabetes of adults. And the problem here, which precipitated her DKA, is that she held the insulin when she was sick. And when you do that, that's a common reason why people go into DKA. And that's one of the things that we have to educate our patients with type 1 diabetes about not holding their insulin. She is, of course, on a premixed insulin, and that's a much more difficult insulin to give if you are not eating, but you should give them basal insulin so they don't go into DKA. So basal insulin needs to be given. So her problem is that she has, of course I don't have her, whether she's acidotic or not, I don't know, because I don't have a pH, so she has latent autoimmune diabetes of adults. Now, there's a second group of patients which also makes the diagnosis a bit difficult in the opposite way. That means most patients who come to you who have diabetic ketoacidosis have type 1 diabetes. But, there are some individuals who present to you with diabetic ketoacidosis who are not type 1 diabetics. Okay? And they're not type 2 diabetics either. Okay? So, to identify them, this is a group of individuals, who have low, beta cell reserve, and what you can see here is that these individuals are classified, this is what is called as ketosis prone diabetes. So if you take them, this group of individuals, and measure their, islet cell antibodies and measure their C-peptide response to glucagon, you can classify them as having antibody positive and having islet cell function, antibody negative, islet cell function positive, antibody positive, islet cell function negative, antibody negative, and islet cell function negative. You see that those who have low C-peptide response to glucagon, they will need insulin, for the rest of their lives, whereas these individuals don't. And this is why they classified as they're type 1A, type 1B, type 2A, and type 2B. as the different types of ketosis-prone diabetes. So for those individuals who are able to secrete insulin, they're actually able to be managed on an oral agent at least for some time. Okay. Now, who are these individuals? They're usually African American or Hispanic or other minorities. They're newly diagnosed diabetics. Usually, they're actually in their 20s and 30s. They're not the usual. If they're coming at age, 15 years or 12 years of age as their first diagnosis, they're not the ones that you see. So they're obese. They actually have family history of type 2 diabetes. And as I said, they have negative islet cell antibodies, and fasting C-peptides are doing fine. So this is something that you have to keep in mind, because before you discharge a patient home and say that they have to be on insulin for the rest of their lives, they don't have to be in these particular groups, of individuals. So it's possible for someone presenting for the first time with an episode of course, if they're coming to you with recurrent DKA, they are type 1 diabetics. But when a first episode of DKA occurs, not everybody there has type 1 diabetes. Okay. So alcoholic ketoacidosis and diabetic ketoacidosis, and you have lactic acidosis. The main thing that you have with alcoholic ketoacidosis, which you can often confuse with this, is the fact that there are ketones in the blood and in the urine. That is why it confuses the picture, and that's why history is very important. However, alcoholic ketoacidosis mainly is because of the shift during metabolism of alcohol from ethanol to acetaldehyde, the generation of reduced NAD, which actually drives the acidosis. And there are three things that are there. What is not so what is not there in patients with alcoholic ketoacidosis is they're not hyperglycemic. In fact, alcoholic ketoacidosis has slightly low blood sugars. If the blood sugar is more than 150, you can basically exclude alcoholic ketoacidosis as a diagnosis. They always have a history of chronic alcoholism. It's not just one episode of drinking, but there's an overlap of binge drinking. And then they're malnourished. As long as they eat something, then alcoholic ketoacidosis will not occur. Because one of the main reasons why this occurs is because when they drink and they're generating more acid in the liver, what is happening is that if they don't eat, their insulin is low and glucagon is high, and which basically is what drives ketoacidosis, and that's what causes the problem. If they eat and if they have enough glucose that is circulating, they won't develop this problem. And of course, the treatment of alcoholic ketoacidosis is to give them glucose, and that will correct their problem. So that's why you have to keep that in mind. History generally will tell you what the diagnosis is. Measuring alcohol in the blood doesn't, because most of these patients have cleared their alcohol by the time they present to you, because it has been metabolized, and it is the metabolism of alcohol that is generating all this problem. So measuring alcohol in the blood will not give you, they're usually negative in terms of alcohol in the blood. In the hyperosmolar state, you have more dehydration, more hyperglycemia, they're hypernatremic and hyperosmolar. So they typically have enough insulin. The patient profile you have here is the older patient, more comorbidities, and most of these patients have recognized type 2 diabetes, but sometimes they may be unrecognized. It usually takes a few weeks for this problem to develop, and dehydration and shock-like status is much more common. So this is the extent of the electrolyte problems that they have. So the hyperosmolar states have much larger amounts of water deficit, sodium loss, potassium loss, and chloride losses, phosphate. So there's a significant amount of electrolyte abnormality that is seen greater in HHS than in DKA. So what do you do with these patients? Do a comprehensive metabolic panel, do a serum osmolality, serum and urine ketones, blood gases. Lactate, basically, if you suspect that there may be an additional component to it, CBC urinalysis, EKG if indicated, is not necessary in all cases. Blood cultures also, if indicated. And this is how we find the usual picture: plasma glucose, arterial pH, bicarbonate, serum osmolarity is less than 320. As I said, occasionally it can be higher. Anion gap is more than 12. Moderate to high serum and urine ketones. Okay, so once you make the diagnosis, what are the treatment recommendations? So this is just the general outline. So one thing that I need to say is that the management of diabetic ketoacidosis and hyperosmolar states are best done if you actually follow a protocol. Using a protocol that is either written or electronic makes it actually easier for the house staff and for the nursing staff, because you can simply write diabetic ketoacidosis protocol and you don't have to do anything beyond that. Of course, there are different protocols that are available, but we do have protocols here and at the VA and also at the different hospitals. There may be some variations that are there between those, and it really doesn't matter that much. Unfortunately, in most studies that have been done, adherence to the protocol is very high in the first 4 hours of the protocol. After that, adherence to protocol falls off, because the first 4 hours the patient is really very sick, and most type 1 diabetics after the first 4 hours actually start doing a lot better. I mean, if you correct their dehydration and the blood sugar starts coming down, they wake up, they're able to respond, and they may be wanting to eat, and so they will start getting better. So at that point, there is a tendency to go off of the protocol, because you're trying to get them out of the unit or do something else, send them home, or the patient is asking, I want to eat. So with all kinds of things, the adherence to protocol becomes less stringent. Now, that is a problem, because often the problems related to either slipping back into DKA or having electrolyte problems or other problems of hypoglycemia are more if you don't continue with the protocol. You actually, by trying to save 6 or 7 hours, you end up having to keep the patient for a day longer, because you went off of the protocol and then you had to restart it, and then everything gets out of line. So that's why it's important to stick to the protocol, even though it may not look like you need to. So the main components of treatment are IV fluids, insulin use, potassium use, and bicarbonate. Okay, so of course IV fluids, it depends on what the extent of the problem is, to determine the hydration status, dehydration, how much dehydrated they are, and then decide about what type of fluid you're going to give, and then of course how long you're going to give that. Insulin, you started along with the IV fluids, and follow the insulin drip protocols that are available in different centers. So there are multiple protocols again, but most protocols are very similar. They may use different algorithms, but at the end of the day, the goal is to get your blood sugars to fall at a certain rate. Usually we start with this protocols using 0.1 unit per kilogram per hour, and then you can always titrate it based on different algorithms that you have. And then it's important to look at the potassium, which we'll go through. Bicarbonate use in diabetic ketoacidosis is not usually needed. If after 1 hour of dehydration or rehydration, if the pH remains less than 7, you might use some bicarb, but most of the time you don't need to use bicarb for diabetic ketoacidosis. As you correct the fluids, as you give them insulin, the bicarb will come back on its own, so you don't have to give them bicarb additionally. So IV fluids, for severe hypovolemia, during the first 1 to 2 hours, give them normal saline. After the initial volume resuscitation, switch them to a lower rate, 250 to 500 cc's, half normal saline, and then of course, if corrected sodium is normal, you give them half normal. If they are low, then you can give them normal saline. And then of course, you have to keep in mind that when the blood sugar reaches 200 in DKA or 300 in hyperosmolar state, change the IV fluids, 5% dextrose and half normal saline, and continue it till you decide that the state has resolved. So these are the conventional insulin guidelines. You know, as I said, there are multiple protocols available, but the main thing is that, you know, you correct the, in DKA, you're going to first make sure that they get enough fluids, correct the hypokalemia if present, you know, and start the insulin. So you're starting with this rate and then titrate it and make sure that it drops by, in the first hour, it should drop 50 to 75 milligrams per in the first hour, and then infuse the infusion rate, and you continue it till the anion gap closes. And then, of course, you know, initiate subcutaneous insulin at least 2 hours before interruption of the insulin infusion. And that's another thing that is forgotten, and I'll come to that a bit later, that it's important to overlap the drip and the subcutaneous insulin regimens. So you have to follow this very closely, because currently we use what is called low-dose insulin infusions. Because in the past, 20 years before, we used to use higher doses of insulin because it was felt that a very rapid reduction in blood sugar was good, but then you ended up with a lot more low blood sugars and caused more cerebral edema, particularly in children. So right now we use less, lower doses of insulin than we used in the past. But this is still a problem. Both hypokalemia and hypoglycemia will still occur, you know, because that's the effect of insulin. Whenever you give an insulin infusion, even when you give it for non-ketoacidosis states like, you know, sepsis and, you know, other things with in patients with diabetes, when you put them on an insulin drip, you always have to be aware that it will drop the potassium and it can always drop the blood sugar quite low. So you have to make sure that, you know, when the blood sugar is reaching your target zone, that you should start to reduce the dose, the insulin infusion rate. And also, you have to remember there's a lag time between the change in IV infusion rate and the resulting effects. Although IV insulin infusion, the half-life of insulin is very short. However, the effect of insulin is much longer. So even though you change the rate, insulin is cleared very quickly. The half-life of insulin IV is only about, you know, 2.5 to 5 minutes. So whatever you're giving goes away very quickly. But the effect of insulin on dropping the blood sugar lasts much longer. So it can drop your blood sugar even after you have stopped your insulin drip. So if you see someone at a blood sugar of 80 and at that point you stop the insulin drip, it will still drop, continue to drop. So that's why you have to be very careful in continuing to monitor them and giving them glucose to bring that blood sugar up. Otherwise, you will end up with severe hypoglycemic episodes. So this is the general continuation orders for DKA and hyperosmolar states. And, you know, you have different algorithm sets that you have. I won't go through this in detail because different algorithms at different places of it are different in what, you know, how quickly they will bring these things down. Except to mention, you know, what you need is you should have a plan on how you're going to deal with a low blood sugar, okay? Because one of the things about diabetic ketoacidosis is that you can give insulin and quickly drop the blood sugar low. It could be less than 70. And if at that point you stop the insulin drip, they will actually go back into ketoacidosis, because if their anion gap has not closed, you have to continue to give them some more insulin. To do that, you will have to give them extra glucose. You know, so either you'll have to bring the blood sugar up, and what we sometimes do is to actually add a couple of amps of D50 to your D5 and infuse it and give them a small amount of insulin, even if it's 1 unit per hour, because you'll have to give insulin until the ketoacidosis, that means the anion gap closes. Otherwise, they will quickly go back into ketoacidosis and you'll have to start the whole process all over again, you know. So, you know, again, you know, after 4 hours of treatment and you're stable, then, you know, you have to lower your, you know, when you have these algorithms where you have what's the rate of infusion, you have to move them from being severely insulin resistant to insulin sensitive. So because severe hyperglycemia and ketoacidosis are insulin resistant states. So you need a lot more insulin when your blood sugar is 400 as opposed to, you know, when it is 100. So that's why you will need to change that regimen. Fluid and electrolyte management, you know, for HHS requires more free water, so you'll have to give them more fluids. And of course, you know, because they're elderly patients, you have to make sure that you're not pushing it too much. as when patients with congestive heart failure, and also make sure that the potassium is adequately replaced. So this is the algorithm that we use for hyperosmolar state. It is very similar, except that your endpoints of treatment are simply different in the sense that there's no anion gap to close. So basically here you're treating them to get their blood sugars under control and bring their serum osmolality to normal range, and that will be what your goals are going to be. Normal osmolality and regaining normal mental status. Again, you have to overlap it. The criteria for when you're going to stop the drip are blood sugar less than 200 and any two of the following: HCO3 greater than 15, venous pH, or anion gap. One thing that you don't want to use is the CO2 measurement, because non-anion gap metabolic acidosis, I'll briefly go over that in a few minutes, is pretty common when you have given so much fluid. So if the anion gap is closed and the blood sugars are doing fine and the patient is awake and alert, you can discontinue the drip. Okay? So the causes of mortality and morbidity are shock, hypokalemia during treatment, hypoglycemia, cerebral edema, which is fortunately rare in adults, and hypophosphatemia, which actually, unless it's very severe, less than 1, we don't recommend treating it, and it's not much of a problem. Acute renal failure, adult respiratory distress syndrome, vascular thrombosis, and of course precipitating illnesses. In general, for the most common DKA that you see, which is actually the non-compliant diabetic patient, really there's not a whole lot. They shouldn't have much of these problems. Most of these problems occur in patients, either type 1 older individuals with precipitating event like foot infection, sepsis, MI, stroke, those kinds of problems on a pre-existing type 1 that actually increases their mortality. Potassium supplement, it is dominantly intracellular, as you know. Urinary losses occur during evolution of DKA, so they're actually quite potassium deficient. So we start potassium replacement quite early in the course of DKA. Even with patients who have normal potassium, we should start them on potassium, otherwise it'll drop low. So if it's more than 5.2, we hold it, but we check it every 2 hours, and then it's less than 3, we'll correct it and then give the insulin, and then here, of course, between up to 5.2, we start the potassium replacement straight away, because we know that giving insulin, giving the fluids is going to lower the potassium levels. As I said, phosphate, generally not necessary to correct it unless it is less than 1 milligrams per deciliter, at which point we might give it, at least for a short time, as potassium phosphate, but we're not going to replace all potassium as potassium phosphate because that will overtreat the problem. Cerebral edema, of course, is a dreaded complication in childhood diabetes. It has a high mortality, and the main thing is a rapid shift of fluids. So that's why in children presenting with DKA, the correction has to be much more gradual than in adults with DKA. So some of the pitfalls are going to be in not treating the underlying cause, not watching potassium levels, and then serum ketone measurements following it. It's not necessary. If you keep doing it, you will extend the duration of treatment because it's not necessary to clear the ketones in the blood or in the urine. And particularly if you're doing urine, it's actually going to increase over time because there is a shift from beta hydroxybutyrate to acetoacetic acid. So that's why we don't want to measure that. And look at the serum bicarbonate rather than the anion gap. And then, of course, stopping IV insulin too soon is another reason why this problem can occur. So hyperchloremic metabolic acidosis, this is common. If you look at your patients' charting, if you see, you will find that most of the DKA patients at the end of their treatment, just before you discontinue the drip, they'll actually have a slightly low CO2 and they'll have high chloride, and that's because they've received so much fluid. All you have to do is reduce the fluids, take them off the drip, and this will correct by itself. As long as the anion gap is doing all right, you don't have to do anything about the hyperchloremic metabolic acidosis that is seen in these patients. The other thing is rebound ketosis because of inadequate insulin dosing. and that will actually increase your hospitalization duration. And this is a typical example of two patients. You can see here, this is the patient whose blood sugars have come down, and this is the beta-hydroxybutyrate. And you'll see that this is a similar patient. The drip was stopped, but this patient, the blood sugar went up, but the beta-hydroxybutyrate stayed low. Whereas in this patient, when the blood sugar went up, the beta-hydroxybutyrate also went up. So that means that this patient is going back into DKA, whereas this patient is not. And that's one of the reasons why you have to be careful when you stop the drip. And some centers monitor beta-hydroxybutyrate. We do have a capability of measuring beta-hydroxybutyrate. The only problem with this is that both at Jewish Hospital and here, the beta-hydroxybutyrate results come back to you so much later that it's not very useful, because if you do a bedside beta-hydroxybutyrate, it will be useful because you know right away. But if 4 hours, it's like, by that time something else would have happened, so there's no reason to follow that beta-hydroxybutyrate because if you do it on there are bedside measures that you can have, just like a finger stick thing, but those things are currently not available. There is another protocol, which is a subcutaneous insulin protocol. A subcutaneous insulin protocol can be used with the analog insulins, the short-acting insulins, Humalog and Novolog or Apidra, and it can be used in a non-ICU setting. And this is a study that looked at three different measures, which is subcutaneous Humalog every hour, every 2 hours, and IV regular insulin, and then of course IV fluids. And what you find is that they get similar results. In terms of the length of stay in the hospital, they are shorter with the sub-Q insulin use. Duration of therapy until glucose is normal is marginally, it's actually shorter here than IV regular insulin. Resolution of DKA is about the same. Amount of insulin use is pretty much the same. So overall, what you find is even if you use every 2-hour subcutaneous insulin administration, you can actually manage DKA without being in the ICU. And the advantage of this is that you don't have the patient, you can send the patient home quicker. So you can use it in uncomplicated mild to moderate DKA, the subcutaneous protocol, and it's very useful for patients who really, the simple DKAs that you see who just come in because they missed doses of insulin, and they're awake and alert, and they can quickly be transitioned to their home insulin regimen. And it should not be used with hypovolemic shock, severe acidosis, comatose state. So any other complications, we don't recommend using a subcutaneous insulin regimen. And then of course you have the final things that you have to do. You have to always look at the precipitating cause. As I said, most often non-adherence to recommendation, insulin errors or insulin pump malfunction. Sick day management is very important to be taught to these patients, like as in the first patient that I showed, not holding insulin when they are sick. That is one of the reasons why this problem occurs. Then of course other precipitating illnesses, and also remember steroid therapy. When you get somebody in the hospital and you give them Solumedrol or other things, they can actually precipitate development of ketoacidosis. And the same things in type 2 diabetes is very similar. It's more common to find more of the renal problems and infections and secondary illnesses in type 2 diabetes as a cause of ketoacidosis. And you also make sure of this when you send them home: diet information, glucose monitoring and test strips, medications, treatment goals, contact phone numbers, and of medical address and surveillance skills. These contact phone numbers are very important. In fact, at Baylor they have a DKA clinic which they run. So these are these regular admissions, the frequent flyers that come in. You can reduce that if you have a DKA clinic and there's someone who can pick up the phone and help them not avoid getting admitted. It actually saves money because, as I said, if each admission costs you $11,000, you actually save a lot of money by not admitting these patients. Because most of them are ran out of insulin and they don't know what to do with their blood sugar, which is high, or they're throwing up or something. So that's something that they can be taught. And again, you have to educate them about the symptoms, glucose testing, urine acetone testing, and of course the social factors as to why this problem is occurring. If it is, supplying insulin is actually a very effective way of saving money here, because of the cost of insulin is certainly way less than the cost of treating ketoacidosis. So I'll end here, and I'll be happy to take a few questions if you have any. Yes. Yeah.
I have a couple actually. One, what is the utility in checking serum ketones if you're pretty sure it's DKA or HHS? It doesn't really figure in the algorithms or as far as
Correct. It's only for diagnosis. So if you know that this is a type 1 diabetic who comes in with anion metabolic and this is what happened, you don't need to measure.
Two, what criteria do you look for ICU admission for DKA versus
Okay,
severe
so
acidemia, I guess.
ICU admission for DKA, as I said, a lot of hospitals, including here, don't allow insulin drips on a regular floor. That's the only thing. There are hospitals, like even at Fort Memorial Hospital, we have convinced them that you can do a drip on a regular floor, and we don't admit patients with DKA. I mean, the reason we admit them to ICU will be if they have significant mental status changes which are out of proportion to their clinical presentation. If they have, any indication, that they're in shock, they're hypotensive, they're respiratory, or any signs of sepsis, then we may admit them into ICU. But for routine, a lot of DKAs who come in because they miss doses of insulin, they can be managed on a regular flow. They'll, recover, without much of a problem. The only sticking point is that, many hospitals don't allow using insulin drip in regular flow. That's a nursing issue rather than a medical issue.
My last question is anticoagulation in patients with DKA.
Mm-hmm.
So a lot of times it's not an issue on the adult side because they have plenty of other reasons to be on anticoagulation prophylaxis. On the ped side of the ICU, they, as a rule, anticoagulate their DKA patients no matter how young.
Mm-hmm.
So I was wondering, without any other comorbidities, acquiring that I've never been taught on this side to think about prophylaxis in a DKA patient due to dehydration. You mentioned vascular thrombosis as a complication. Is that something you should be thinking about? Or
No, I mean it's very rare, so it's not something that we, recommend, unless there are other reasons why they may be having problems. But otherwise, no.
So, any other questions? All right, guys. Thank you,
Okay,
Dr.
thank you.
Mokshagundam, for coming.